Louise described us as healthcare veterans, which is code for old.
Gray hair.
Coming up on 30 years. So thanks everybody for your attention and for a couple of our front row seaters. Those of you in the back, don't worry, you won't get called on. We're going to talk a little bit, I think really dovetail off the conversation that the panel just had around the experience of consumers that are participating in health plans particularly. The title of the session references the CAHPS survey. How many in the room are familiar with the CAHPS survey? Just by show of hands. Maybe a better question is how many are not. It is, of course, a perfectly predictive instrument, we would all agree. Highly accurate, with a very appropriate sample size that should be used to make a bunch of decisions, or not. Unfortunately, it's increasingly very important to the overall financial performance of a health plan, particularly obviously in the MA space. So we're certainly going to touch on CAHPS, but I think what I'm also really interested to do with Ingrid Lindberg, who's going to introduce herself by giving her background, is touch a little more broadly on how do you get information and data that you can take back inside your organization to drive the kinds of experiential changes that improve outcomes and results. So if I get data that says the call center stinks, then I can go down to the call center department and I can have a conversation, try and move budget, try to drive that experience. So we'll talk a little bit about those things. But first, I'm really grateful to have Ingrid join me. So far I am. We'll see how we do. And I thought a great place to start, Ingrid has the distinction of being, as far as we can tell, the first customer experience officer in healthcare. We've done a ton of extensive research and we didn't see anybody else that had that title before Ingrid. But it was at a time when healthcare was trying to embrace the customer experience. And so maybe just talk a little bit about your background so folks know from whence you come as we get into the conversation.
What an intro. I don't know how I feel about any of those words. So far, so good. I don't know how I feel about her. I mean, talk about setting me up for success. Hi, everyone. I'm Ingrid. It is delightful to be here. Steve, thank you for the invitation. And Carrie, thank you for the introduction. And I was asked to introduce myself. And I said, look, I use self-deprecation and humor because I'm an Irish Catholic girl from St. Paul. So this is really going to be bad. Or it'll be good, one of the two. I grew up in financial services and had the distinct pleasure of being one of those people who had to start learning how to design for human-to-computer interaction back in the 90s when we were turning on websites and people could use them, and studied under Alan Cooper, who is the father of all things persona and all things UX, so user experience design. And I spent many, many years in financial services building some platforms and some products, and was in New York in 2001. Catastrophic moments sent me back to good old St. Paul. And I was walking through the Skyways one day and ran into a delightful old friend of mine from my Watson Wyatt days. He said, "Are you still in finance?" And I said, "Yeah, sort of." He said, "Well, we're starting a healthcare company." And I was like, "I need a job." And that company was Definity Health. So was at Definity Health in the very early days of building the first consumer-directed healthcare plans. So I've officially just hit 20 years in healthcare as of January of this year, which is insane to me. But we did an enormous amount of work around consumer engagement at a time when people were not even talking about consumers, right? There was no consumer in healthcare. People would say things like, why does how a member feel about us matter? The employer is the buyer. Sound familiar to any of my old folks in the room? We sold Definity to United. Hello, United friends in the room. I was one of the founders who fled. There was a group of us. I went to Cigna and was given the title of Customer Experience Officer. That happened in 2007, and the story that I love to tell about this one, that I always have to do a fact check on when I start, is when I got this job, I said, what on earth does that mean? So I went to LinkedIn and typed in customer experience. And there were three people who had customer experience in their title, 2007, November, on LinkedIn. So every time I tell this story, I check the morning of. Anyone want to venture a guess how many there are today? Without looking? 4.93 million. We definitely care about CX now, a lot more than we did in 2007. So I've been doing this work around company to person design for a really long time across a bunch of industries.
And you're now working closely with, in a consultative capacity with health plans across the country.
Yep.
To help redesign.
There's my feed. He was like, kick, say this. Thank you, Steve. So I went from Cigna to Prime Therapeutics, spent 3 years doing the transformation there. And in 2015, started my own firm called Chief Customer. We work across primarily financial services and healthcare. And we love the entire healthcare ecosystem. So I've got about 70 employees. We do customer experience work for pharma, for payer, for integrated health systems. And every single one of the 70 people that I have the pleasure and privilege of working with were people who worked for me at either American Express or Cigna or United or Definity or Prime. So there you go.
When you look across that universe of health plans are near and dear to our hearts, typically the primary client that we serve. But when you look, maybe before we get into the health plan world, payers, pharma, providers that are taking risk, when you're working with those entities, who's moving the most quickly? Who is shedding maybe some of the legacy language to the earlier panel and approaches the most quickly?
So I think the most interesting thing that's happening right now is there is a design and innovation center that has been set up in Singapore. And it is funded by the government. And they have brought in what they believe are the top 15 thinkers from US companies. So it's Meta, it's Google, it's also places like J&J and places like Merck, known as MSD globally. And what they are doing there is consumer health behavior change, primarily funded by pharma. And I will tell you, the stuff that they are building, I listen to people talk about the navigators, right? And then I immediately go to GPS. Like, I never wanted a navigator to tell me how to get to somewhere. I don't understand north, east, south, west, right? I don't. I want to get in my car and I want to say, I live here. How do I get to the Nicollet Island Pavilion, right? How do I do that? I want someone to just take me and get me there. And some of the things that are being built in that innovation center are, you don't need a navigator, you don't need a simplified language, you need to solve the core problem behind it. And they're doing some interesting stuff that they're gonna try to launch and change some big behaviors. So that's what's interesting.
One could argue that CMS's emphasis on CAHPS and on the member experience more globally is similar to what the government of Singapore is trying to do, which is improve outcomes, lower costs, make it easier for people to access healthcare. We can debate whether or not CAHPS is a great instrument, whether CMS has got all of their priorities right, but certainly I think that's the pressure that's being put on the scale. As you think about maybe specifically in the health plan environment, you go back to your Definity experience where you're working with employer groups largely. The ROI equation wasn't that important. It was about the employee experience, maybe lowering total cost. How do you think about the applicability of maybe learnings in the commercial environment and how those translate to Medicare Advantage, seniors, or maybe more interestingly, Medicaid and some of those populations? And the customer is a very different profile or persona, to quote your
For sure, right? For sure. So I think one of the misnomers in our country is really around this kind of belief structure that, commercial is easier, government is harder. I hear that a lot, right? Government is so hard. Government programs are so hard to manage and run, right? And one of the things that we have seen time and time again, we'll piggyback on the prior panelists, right? So 51% of Americans would struggle to read a book written at an 8th grade level. That's a huge stat, right? 51% of Americans would struggle to read a book written at an 8th grade level. You start thinking about when someone actually becomes profitable for a plan, right? We've done research that shows specifically in the Medicare space, One of your members will not become profitable until their 4th year of being with you in a customer lifetime value model. Have any of you done a CLV? Not a single hand, right? So when do your members become profitable? Who matters? Why are they leaving you? Why are they choosing you? And the last stat I'll give you on why does this even matter, right? Commercial versus any type of Medicare, Medicaid, senior population. 86% of Americans have choice now. For years, we were like, oh, you get what your employer offers you. Well, we know that's actually no longer the case, right? You can choose what your spouse has. You can choose a government plan offering. We forget that choosing to not have insurance is a choice, right? Not included in that stat, but the vast majority of people have choices now. So how you can help people make the decision to choose you and stay with you, which I think CAHPS is trying to get to, right? Which I think CAHPS is trying to get to, is the new challenge.
We have done work. I've had the chance to spend time with one of the leaders from Blue Cross Blue Shield of South Carolina who's used surveys. There's a terrible brand for it. It's called a pre-CAHPS survey, which basically means I'm avoiding the blackout window and asking relevant questions. But has used them to great effect to glean insights that he can then use inside that organization to reallocate dollars, to reprioritize retail versus mobile app versus community events, and really have hard data coming back from the actual membership to make decisions inside the plan and champion these strategies inside the plan. When you think about, you've done 2,000 surveys in the last couple of years, 5,000 surveys. When you think about best practices, A, around survey design, but then B, how do you take the insights from that survey inside the organization and drive change? And I can give a couple of examples from South Carolina, but I'd be curious sort of more globally how you've seen that work well, or individual leaders who've done a good job of getting data to go get something done.
So 2 parts. So best practice on survey and then best practice on data use. Can we do it that way?
Yeah.
My brain has to split things, right? So best practice on surveys, let me use my channel. Don't blast through every channel known to man. Let me use my channel, right? So if you can figure out channel of choice, it's going to work better. Number 1, shorter is better, always. We tell people that it should be 5 questions or less if you want a real answer and you want completion rates. Not, we call it stopping the survey madness. I don't know about you guys, but if I get one more Qualtrics or 4C or Foresight pop-up on a web, I'm shopping for shoes. Yes, Bloomies, you don't have it. Yes, Target, you don't have it. Yes, DSW, you don't have it. But every single one of you gives me the exact same survey from the exact same company asking me very different questions about my experience, right? So there's a lot of ways to get much smarter about who you ask, what to, when. Who you ask what to when, and I think that's really hard. That is not something that most of us have solved yet, specifically in this space. So I'll stop with, those are my 3, and in plain language, right? It's gotta be at 5th grade level, guys. It's not even a discussion. It's just, it has to be at 5th grade level.
And to what degree does embedding action in the surveys make a difference in your experience? So do you have a pharmacist? No, I don't. Pops. Click here to connect with our pharmacists. Are you seeing differences in yield when you put those action steps in there?
So I think this is one of my favorites, right? It depends on who you're asking. It depends on who you're asking. So if you ask me a question about my experience, and then you interrupt what I think is going to be a 5-second survey, right? Because you've told me it's 5 questions, and then you give me an action, there is a high likelihood that you have really just pissed me off. And I'm going to close out the survey before finishing. Now, if you ask my mother, who is 82 and is sitting at home, and her best friend in the entire world is her brand new laptop, right? She's like, oh my goodness, I can find this too. It's delightful. And I'm not saying that every 82-year-old would have that response. I'm just saying it's about the ability to flex and not make the assumption that one proposition will yield the same result from any person who might actually see it.
Let's go back to your Cigna days on the second question. You go get a bunch of data from the membership that says, I'll just pick on something we all hate. The provider directory sucks, which hasn't gotten any better since 2007, I don't think. How were you most effective as the, only the fourth person in the country with the title and the first one in healthcare, running around a place like Cigna with data, getting the other leaders in the organization to align around the insights from that data?
I have so many bad stories about that time in my life. So my CFO, who is no longer at Cigna, so I get to talk about him all the time, and I've told him I do this. I'm friends with Mike Bell, so I can say this about him. But I remember when he looked at me and he said, "No money, no mission, Ingrid. The money's more important than anything else." And it took me a second, because I can be witty, but I need like the 5 seconds to think. I'm not like Corey, who's, right? I mean, he's fast, he's smart. I have that like moment, and then I can throw something out. And I looked at him, and I said, okay, so what you actually have to remember is no member, no money. No money, no need to count. No need to count, no CFO. I didn't make a friend, but it worked. So best practice, what I tell people is that, first of all, start with a voice of customer counsel. Your data should not be held by one entity. If you hold it with one entity, then that person or that group becomes really dangerous and people dislike them thoroughly. That's number one. Number two, you have to actually figure out a prioritization methodology, because the reality is I can't make the decision about what should be happening if I am a line item leader, right? If I own a call center, if I own the web, I'm going to use that data to my advantage. And people use data like a weapon every day. We've all experienced it, right? One of my favorites is we'd done work. This was at Cigna. And we had found out that our contact center was a huge problem for us. It was a huge problem for us, right? We were a business of caring, Monday through Friday, 8 to 5, Eastern Standard Time. That's not when anybody needs you, right? And we had sat down, and the head of the contact center, at the time his name was Bob McVeigh, was like, well, look it, we clearly have to do something right away. We've got to fix all these things in the contact center. And I said, yeah, but the contact center is less than 6% of the customer experience. So that's not where we should spend our money. We know that communications and the provider directory is almost 30%, because it's why people choose us. They can't find their doctor. If their doctor isn't in a network, they're not going to choose us. So yeah, we've got some things to fix in the contact center, but that's not the most important thing, which is why I say you can't ever let a line item leader or a line leader own what that data does. It's always driven through counsel, because then you actually have the ability to use a prioritization methodology to make smarter decisions than just whoever's screaming loudest. And everybody will use the data, right? We will all use the data as a weapon. It's human nature, I think.
Interesting. It sort of reminds me of that everybody gets you can all have your own opinion, but there's only one set of facts. But apparently, line leaders might twist those facts. I think about, in conversations I've had with some of our clients that have done innovative data gathering, AKA surveys, lightweight surveys, pre-CAHPS surveys. You could put a lot of labels on them. One of the things that's been interesting is studying not just existing members or clients or customers, but former or disenrolled members. What's been your experience in learning more from what you lose perhaps than what you've got, as you think about strategies to get data to drive change inside your organization?
I think that the two most important questions in healthcare specifically, and in health insurance most specifically, are why did you choose me, and why did you leave me? It's not why are you staying, because why are you staying is inertia. I hate to break it to you. Why are you staying is inertia, right? The stat, the 2022, I think this was Edelman's Trust Barometer, that less than 50% of Americans trusted health insurers. Less than 30% of Americans trusted the government, and my kind of snarky comeback to that was, so the 50% of people who don't have an opinion or who still do trust their insurers are the ones who haven't actually used their benefits yet, because it kind of lines up pretty nicely with what we see, right? But sorry, it's true. And so I think the magic, right, the magic in this is figuring out why do people choose you. We know people, the 3 things they look for: doc and network, drug on formulary, and cost. Those 3 things have not changed since 2002 was the first time we did the research. Those 3 things are the 3 driving forces. So what are you doing to make it easier for people to choose you? And then, why did you leave? I love studying when did you leave. Did you leave on the 3rd month? Did you leave on the 5th month? Did you leave after you tried to fill a prescription for the first time? After you tried to see a doctor for the first time? After a claim was denied for the first time? Those bits of data, that's the magic. That is the magic.
It's interesting, the couple of data points that I've looked at where the rating of the plan does drop quite significantly after these firsts. I'm curious, have you seen strategies where you anticipate that post-first reaction and try to instigate some kind of outreach or communication or offer to help? Or I loved Marcus's comment in the last panel, thank you for filing a claim. We're sorry that there was a problem with it, but we appreciate, have you seen examples where you try to anticipate that first reaction, post-first, if there's such a term?
There are 2 fabulous ones. One is financial services, which I know is not healthcare, but I want you to listen and learn on this one because it's groundbreaking and crazy and amazing. And then I'll give you a good health insurance one. The financial services one is a bank that we were working with, and very similar, right? People leave. People leave their bank. Why do you leave their bank? And what we found out was that people were leaving because they bounced a check. And it wasn't the people who bounced like 6 or 7 or 8 or 9 checks. Credit card transaction, insert whatever line you want to use for this, right? My mom still does write checks, so it does happen. But never a bounce, never a bounce. And so we implemented a program that said we would never actually put your account into the negative and penalize you on the first time. We would cover it. And people were like, oh my gosh, people are going to abuse this and it's going to be horrible and the world's going to end, right? Well, guess what? Most people who bounced a check, bounced a transaction, overdrew their account, were able to solve it almost the next day. And so they got a very rapid response outreach saying, your account balance has gone negative. You need to stop using your card, your ATM, whatever it might be. We're going to give you 48 hours to fix this, but we're not going to penalize you. And the reason that was important for them was it was so much more expensive to go get a new checking account member than it was to actually just cover that overdraft. People didn't abuse it. If you did it again, you were booted. But they are still, if you watch TV around this little area, you will see them talking about the fact that they don't charge you for your first overdraft. They've had an incredible uptick in retention. They've made more money because they're not out chasing new to the same degree. It's just a beautiful example, right? On the health insurance side, I think one of the things that was most interesting to me was a company we did work with around first fill. So we knew that the first time that most people will use their benefit is when they walk into the pharmacy, right? In a lot of cases, if you're looking at calendar year, that happens on, first 15 days of January. We had a huge influx of calls because my drug isn't on formulary. I didn't fill out all the things I needed to fill out. You didn't give me my permission slip in time, so I didn't get the right drug. And so what we said was we will never deny a first fill. We never will deny a first fill. We'll always fill that first one. Whether you're at retail, whether you're doing it through our mail order, we will never deny a first fill. And it changed how we processed a lot of different things. It gave us an opportunity to have people because we didn't just deny. Right? So we reached out, said we're not going to do the second one. We did the first one, but impactful, stopped the bleed. Yeah,
it's interesting. One of the pieces of data that I looked at in preparation for this conversation was a CAHPS survey that was, or pre-CAHPS, I should say, very focused on things like your first experience with your prescription fill, and the difference between the people who stayed with the plan and didn't was 4x. Mm-hmm. And it was all around that first fill experience, which is an interesting correlation. When you think about, you're making fun of Mike Bell. This is really, we are dating ourselves up here.
Small world we live in, people.
He's retired on an island somewhere now, isn't he?
Turks and Caicos.
Yeah. But when you think about that money mission thing, I think one of the things that is unique from a transformation standpoint for those of us that are trying to improve how people experience healthcare, and particularly those of us that are wearing a health plan hat, which I think, as Liz mentioned in the prior panel, is, it's not the greatest place to start from an industry perception standpoint. But MA is unique, and CAHPS as a proxy for a satisfied consumer experience, satisfactory consumer experience, with all of its flaws and imperfections, drives the incentive and the economics for the plan. So there is that money-mission correlation there that I think makes it very, very useful. I'm just curious, as you think about some of the transformation you've been involved with, how important was not only being able to identify, I like the concept of a customer council as opposed to a line manager weaponizing data. I think that's a key takeaway for me. How important is it to have a business case around that transformation, and where have you seen that done really well?
So I am a firm believer that you have to hire people that can do things that you can't, and I don't do business cases. My friends who are here, who have been with me, who have listened to me pitch the why we should do something, can all attest to that. And my stupid human trick on this one is I always, whenever I started a new company, right? Oh, Ingrid, welcome to insert here. Here's your new financial analyst. And then I steal them and make them my chief of staff because they understand how to manipulate the CFO, which is an art. It is an art. And they are part, you have to smile at that. That wasn't that scary.
I would get fired if I tried to manipulate the CFO. So.
True, good point. Oh, I don't know if you get fired. You might be able to play a game. But you do have to be able to figure out how to put something in their language. And so what I've said, especially for the last 10 years of doing this, is don't talk about customer experience. Talk about the business results. I wrote a blog on this thing 10 years ago that literally was don't talk journey mapping, don't talk, CX, don't talk scores. Talk about the money you're going to make. Because at the end of the day, that's what the business case has to be. And almost everything that one of your members, customers, patients, whatever, even on the provider side, most of the things that they're asking you for are things that are actually going to make the company more money in the long run. Whether it is they're going to stay with you for longer, so you're going to be more profitable, you're not going to have to replace them. Whether it is they'll use their benefits better, one of my favorite lines, right? They'll use their benefits better, but there's always an ROI on these things now, especially with what we've seen with CAHPS and payment being attributed to a member experience score.
Yeah.
There's always an ROI you can find, and they're really strong if you're doing the right things.
You talked earlier, and I see we're near time, so maybe I'll just, and I also know we're between this group and lunch, which is, I feel bad for the 2:45 panel because they're in front of happy hour.
It's an early happy hour, it's fine.
Three's not early. It is early. Just quickly, you talked about channel. Talk a little bit about just when you're trying to drive the kind of connection and engagement with people who are, in our case, members. I think of them as people, but they have this other label. And then when they go use their benefit, they're called a patient. And then when they get home, they're called a sister or a friend. But when we think about the lens of a customer of a health plan, particularly, I think, again, in MA, where I've selected it, I've chosen it, it hasn't been assigned to me by my employer. How important is it to find ways to personalize the interactions with those individuals? And when I think about developing a relationship, loyalty, length of membership, 4 years to be profitable, the average churn in an MA plan is 9.5 months for lost members. How much can personalization play a role there, and what have you seen work particularly well?
So I have seen and I have learned that personalization is a very dangerous place. If used well, it's magic. If used poorly, it's horrific. And I was lucky enough to do a bunch of work with Best Buy when Uber was there. And I don't know how many of you still get a Best Buy mailer or if you have the Best Buy loyalty card, right? But the level of personalization that they're able to pull off is amazing. Right? It is based on what you bought. It's based on the last time you were there. It's based on kind of your average spend. I ran their loyalty program for many years, and it's just amazing what that marketing team has been able to do to make that connective tissue. I think the dangerous part in healthcare is, we've told the stories for years, right? Don't show up with a mailer about me needing to take Viagra at work, That's like the oldest joke I've heard 5,000 people tell on stages. And at AHIP 3 weeks ago, for anyone who was there, we will not name who did it, but I was like, really? Again, we've been hearing that one for a while now. You have to be smart about it, right? You have to actually think about what you're using, what you're saying, who they are. Because I think within the personalization, it's not just the segment and the message, it's the persona. So what is their driver set? Do they want to hear from you? Do they trust you at all? Have you figured out whether or not they're engaged in any way, shape, or form, right? You've got to actually earn the right to use personalization with me. I'm the antithesis of the customer you want, right? I'm like, I don't trust you, I don't like you. Don't send me anything, please. If I need you, I'll call you, or I'll send you a chat. And if you can't chat me, then I don't want to talk to you. But I think that you have to figure out who is interested in it, and then use it, 3 steps back from skeevy.
Yeah.
Right? 3 steps back from skeevy. Find that spot.
Yeah. Excellent. Well, thank you for sharing your experience and insights. Well, I'll leave you with one final thought, which is one thing that we've seen done extremely well, and you've built a career out of it, is getting hard data from the individuals you are attempting to serve that allows you to look in a mirror and see how your benefit, I think Liz used the example, I got from 40 pages to 35. Like the ability to capture and then act on that data is really, I think, probably one of the most important things we can do as leaders. And what we've seen in MA, we certainly see this in managed Medicaid to a degree as well, is that the payment mechanisms are rewarding us for getting those insights and acting on them, which allows us to build that business case inside our organizations. And if anybody needs help figuring that out, Ingrid would be happy to help you. Thank you very much.